Welcome back to this week's edition of Freedom and Prosperity Radio, the weekly radio news magazine we put together here at the Virginia Institute for Public Policy. My name is Joe Thomas, and again, our archives are kept on a YouTube channel. Search Freedom and Prosperity Radio at YouTube, and you can learn more about us at virginiainstitute.org. Our next guest is Senior Fellow at the Cato Institute in the Department of Health Policy Studies. Dr. Jeff Singer is back on the program with us to talk about COVID-19 coronavirus and specifically COPN. No, that's not one of those acronyms that leads into COVID, but it could have an impact on it. Dr. Singer, welcome back to Freedom and Prosperity Radio. How are you?
I'm good, thanks. Thank you. Staying inside. Yeah,
I think a lot of us are doing social distancing, and some places we do it more than others because we just, we don't like each other, but it makes it easier. Charlottesville's been social distancing since 2017. So this came up as just as a hypothesis. We were talking about the president's urgent call to start more, scanning, test areas, parking lots. You mentioned some of the chain pharmacies and Walmarts and that kind of thing. And it made me wonder, I said, do those need to go through the certificate of public need the same way somebody who wanted to start a CT scan business or an MRI business would? And then it also was pointed out to me that South Korea's great success with COVID-19 has actually come from the fact that they use CT scanners to identify patients there. So you take us into, first, what certificate of public need, laws are in Virginia, and why are they tripping us up in our preparedness for and our reaction to coronavirus?
Well, certificate of need laws, they call them in Virginia certificate of public need, but certificate of need laws came into being as a result of a federal law passed in 1974 in the Nixon administration. And that law basically gave federal funding for states to set up these boards that would review whether or not hospital beds were needed or any sort of health care facilities were needed, because they actually thought, and this is kind of hard to believe, that by reducing redundancy in hospital beds, CAT scanners, etc., that they would decrease healthcare costs. So in other words, even though it kind of runs counter to what you may have learned in your high school economics course, they believed that by reducing supply, they would make the price go down.
Amazing.
Even though that's not what we were taught. Well, most states complied with it, and by the mid-1980s, it became apparent that wasn't having its intended consequences. So the law was repealed in 1987 in the Reagan administration, and several states repealed all or most of their certificate of need laws. California did. Arizona, where I'm speaking to you from, repealed all but the one dealing with ambulance services. But there's still roughly 38 states that have certificate of need laws to one degree or another. Some cover more things. For example, Ohio still has certificate of need laws for long-term care facilities, but nothing else. Pennsylvania is one of the states that removed its certificate of need laws in its entirety. So what you have is a situation where, if, depending on your state, if you want to add a wing onto your hospital and add more beds, you need to go before this commission, which has either staffing or input from the other hospitals, to say whether or not we need this amount of beds to serve this population. Which, it's a concept that you could see maybe in the old, rusty Soviet system kind of days, where you had a centrally planned commission decide how many shoes people need, how much bread people need. But that's what we have when it comes to health care. And depending on the state, if you want to add on a CT scan machine or an MRI or a PET scanner, you need to get permission. You may need to, if you want to build a freestanding ambulatory surgical center or surgery center. In Virginia is one of those states. You need to get permission. And oftentimes, the people you're trying to get permission from, like I say, are potential competitors. So I like to use the example of, imagine if we had a certificate of need law for restaurants.
Oh, yeah.
And you got this real nifty idea for a new concept in cuisine and dining, and you want to open up a restaurant, but it has to go through the approval process, and most of the major restaurant owners have a voice on a certificate of need commission. And they say, well, it's an interesting idea, but we really don't need another restaurant here, so maybe some other time. And that's what would happen. So that's kind of what's happening. So as a result, there's no flexibility. There's no ability for anybody in the healthcare sector in those states to respond to market demand. Now, nobody knows the right number of hospital beds at any given moment in time, just like nobody knows the right amount of shoes we need to make. The market, supply and demand, is what answers that question, and pricing is the signal. So those states, we're worried, of course, with the COVID pandemic, that regardless of where you live, your healthcare system might get overwhelmed because we could be met with this deluge of patients that nobody could ever anticipate.
Absolutely.
And that's what we're worried about. That's why we're trying to minimize the spread by keeping everybody self-quarantined and socially distancing. But it's obviously in states that didn't have that straitjacket on healthcare systems like Virginia does and other states with certificate of need laws, we would expect that there'll certainly be more availability, and there's also more ability for facilities to respond. Mm-hmm. For example, I just learned that in Maryland, the governor has ordered to kind of take out of mothballs several state health facilities that had been shut down and dormant just to make more beds available. So that's the point is that we can't expect to build a hospital in 2 weeks. Although in China they built a 1,000-bed hospital in 10 days. But when you don't have the constraints of a commission where you have to get permission to add beds or add X-ray machines or ICU beds, where you could just act in response to demand, that certainly makes things move more quickly. And from what I understand, there was just about in 2018, a study was done by the Mercatus Center at George Mason University, where they compared Ohio, Pennsylvania, and Virginia. Ohio they repealed their certificate of need laws with the exception of long-term care facilities. Pennsylvania repealed their certificate of need laws entirely, but Virginia keeps theirs in place. And what they found since the repeals, that Pennsylvania's hospital bed per population hospital bed numbers have come down, even though their certificate of need law was removed. Ohio's went up slightly. Virginia's, though, came down dramatically, way more than Pennsylvania's. And now, when it comes to rural hospital beds, mm-hmm. and also the number, when it comes to rural hospital beds, Virginia's are much lower than they were. They dramatically dropped in comparison to the number of rural hospital beds in Pennsylvania and in Ohio. And when it comes to surgery centers, we like to see more surgery centers because we like to be able to do more things outside of the hospital, which mm-hmm. are less costly as well than in the hospital. Well, the rate of growth of surgery centers in Virginia compared to the rate of growth in Pennsylvania has been much slower. And in fact, in rural areas, the rate of growth of surgery centers has been dramatically lagging behind Pennsylvania. So now we have a situation in Virginia where let's hope we don't have the worst happen, the worst case scenario, but people in rural areas of Virginia will have less access to hospital beds. And people who are needing surgery, obviously, if it's an ambulatory surgery, it's unlikely to be an emergency. But still, they can't get the services that they can get in other states because of these restrictions placed by commissions, these centrally planned commissions, which are generally, run by the incumbents. People who you're asking people with whom you want to compete, if it's okay for you to compete with them. I mean, it doesn't take a lot to figure out what's wrong with that picture.
You know, it's interesting here in Virginia, we have a dynamic in our General Assembly where many people campaign for office and won office in many cases on the idea that the electric utilities had gotten in bed with the politicians that were regulating them, yet they seem to be perfectly fine, if not blind, to the fact that a lot of the hospital systems and health insurance companies are doing the same thing with these certificate of need regulations. When you talk about states that repealed them, what were some of the common, hurdles that were put forth? Because in Virginia, we don't have a problem necessarily getting change in our legislative process. It's overcoming the rhetoric of, those who want to stick their head in the sand and keep things status quo. What were some of the winning arguments in some of these states like Pennsylvania that were able to overthrow their certificate of need laws, if you have any of that?
I'm sorry, but I didn't follow the debate in Pennsylvania. And what was interesting, though, to my surprise, in Arizona,
okay,
one would have expected the Arizona Hospital Association to fight it. With the hospital associations in the various states are the ones that they try to make arguments that it's in the interest of public health for them to control the amount of beds available. That redundancy is not in their best interest. In Arizona, the hospital association actually supported it, which came as a surprise to me, a pleasant surprise. But unfortunately, I don't know.
Well, I just picked Pennsylvania.
In other states.
Well, no, the Arizona one is fine. I was just looking for any example of, the way the argument was made, because we'll make the argument here. We just don't want to kind of stumble around in the dark trying to find, the winning formula. And so, any data points on places it's worked before is fine I just picked Pennsylvania because they were a Commonwealth.
One example is, to compare the states like California, Arizona. There are a number of states that don't have certificate of need laws at all anymore, and Pennsylvania is a nearby one to compare to, and there have been comparison studies. What I think, though, is interesting, and it is happening with a lot of things now in response to the public health emergency we're having. So I think we're hearing now, for example, governors in many states waive the onerous licensing requirements for healthcare practitioners.
Yeah.
So you may be aware that about 2 years ago now, Arizona became the first state in the union to say anyone who has a license in anything that's licensed, whether it's healthcare, law, or general contracting. If you have a license in good standing in another state for at least 1 year, then if you move to Arizona, you'll be granted reciprocity. Your license will be recognized here. You'll be given a license to practice your profession or trade in our state. And recently, Pennsylvania followed through with the same thing, and just even more recently, Utah did. Well, now, in response to this crisis, several states, including Maryland, Massachusetts, South Carolina, they've issued emergency. The governors have issued emergency orders saying that if you're a healthcare practitioner, a nurse, a respiratory therapist, a doctor, and you want to come to our state to help with this, we will grant you reciprocity. In Massachusetts, it'll grant nurses reciprocity within 24 hours, as long as you have a license in good standing in one of the states from which you're coming.
Yeah.
And so, first thing that comes to my mind is that's great, but if it's good to do it for them, why not do it for everyone? And why do we have to wait for an emergency to happen to remove obstacles for people who want to come and meet a need that people have to have filled? Why should we make it only last as long as this crisis and then have to do it again the next crisis? Obviously, the governors have the authority to do emergency executive actions, and then to make it permanent, they would require legislation. I understand that, But so I think we should be taking the same approach when it comes to certificate of need laws. If they could build a 1,000-bed hospital in 10 days in China, I'm not saying that that's going to happen overnight throughout Virginia, but we'll be allowing hospitals and other healthcare facilities to add on things and convert sections of their hospital that might be quiet right now into wards where they could add beds to an area that right now, let's say, is housing, endoscopy. And now they got more hospital beds where they don't have to go through all this approval process. So because this emergency, governors can suspend the certificate of need laws as an emergency. And then take that opportunity when the emergency passes to say, we learned a lesson here, didn't we? We need more flexibility. I asked the legislature now to make permanent what we just did temporarily in this state of emergency, and that's what I've been advocating. There is a silver lining in this terrible story we're all going through right now, which is as we're trying to deal with the crisis, we're discovering all of these regulations that have been in the way of us responding quickly.
Well, and certainly I think in healthcare in general, we see this idea of almost protectionist cronyism going on, where insurance companies want to keep their piece of the pie, or maybe perhaps become a government mandated piece of the pie, that kind of thing. Is it a partisan issue, Dr. Singer? I mean, you mentioned Arizona, Pennsylvania. I mean, they've had lots of different, Democrat, Republican governors and legislators. Is this something that only Republicans like or only Democrats like, the removal of the COP or the CON laws?
My understanding is no, it's not. It basically has to do with special interest pleading before the legislature. There's bipartisan support of removing certificate of need laws. The same, by the way, also with occupational licensing laws. Mm-hmm. I mean, we're seeing, in the last years of the Obama administration, there were task force that were looking into getting states to reduce their occupational licensing laws, which have restricted entry into the workplace for a lot of people. So the same can be said for that. There's actually bipartisan support for these kind of ideas. So the main obstacle is basically heavy lobbying by special interest groups who try to persuade legislators that it's really in the best interest of the public that they be able to maintain control over the supply.
So at the end of the day, it is as simple as supply and demand for those who would say, oh, healthcare is beyond a supply and demand scenario. What about the argument that it costs an awful lot to be a hospital, to start a medical practice, to even get a medical degree? So we need to protect those who do that or who take on that heavy cost so that they can make back their money. It seems counterproductive, but I have actually heard people say that you can't just have a hospital on every corner. You'd run out of doctors because nobody would want to do it. It would be like being a Burger King manager.
Well, the way I look at it is, again, our biggest interest should be on the consumer in a free economy. The consumer is the person we're interested in. So if there are, too many doctors, then that means doctors have to compete for the consumer's business, and they have to lower their prices. The same thing with hospitals. I don't see a problem with a consumer having more choice. In addition, we need to look at there are other obstacles, of course, because the states have scope of practice laws, where the states could set the laws as to what different kind of healthcare practitioners could do what. And there are a lot of healthcare practitioners who are qualified by their training to do a lot more than they're permitted to do by the licensing board in a given state. So there are a lot of things, for example, that doctors who went through years of training are only allowed to do, that many people who have less training but are good are more than adequately qualified for providing certain things can be doing, like nurse practitioners, physicians' assistants. In a case of dental care, there are several states now that are going to that are allowing the practice of what are called dental therapists, which is sort of like dentistry's version of a physician's assistant, particularly in underserved areas where they could do a lot of the things that a dentist could do, even if not some of the more complex things. Yeah. So the way I look at it is we're supposed to be interested in the consumer and the patient, not in so much the person who's providing this good or service to the consumer. We just want to make it easy for the person to provide a good or service to the consumer. We have people who want things, and we have people who want to provide them with things. We should make it easier for both of those people to meet one another. That's the way I look at it.
Dr. Jeff Singer, Senior Fellow at the Cato Institute in their Department of Health Policy Studies. Is what you were describing there, sadly often what happens when government inserts itself thinking it knows how the market works, better than just those who are engaged in it? Yes,
nobody could know. That's why every time we've tried price controls, we've wound up with shortages because nobody could, and look at Venezuela, they're a perfect example of that. Nobody, no matter how smart you are, can presume to know how many of a given good or service, how much of a given good or service is needed at any particular point in time. Every one of us has our own context. We're in our own particular set. We have our own particular set of priorities, which are shifting from moment to moment. There's no way anybody could properly plan for that, which is why we have a market. The market, through the forces of supply and demand and mediated by price, is what gets that information out there. And it's the most efficient way of delivering the most goods and services to the most people at the least cost.
It's an absolute, head slapper because you'd say this is obvious, but it doesn't seem to strike into the hearts of our elected officials. What is your prognosis then going into the last question as we are in the grips of coronavirus? I don't like any decision made in panic, but is there an urgency in this that, doesn't quite reach the panic level, but that will, drive some of these decisions, do you think?
Well, yeah, the main concern is that we're expecting, based upon experience in other countries, that we're going to very soon, in the next week or so, start to see a large surge in people who are becoming clinical, clinically exhibiting a coronavirus, and then going to emergency rooms, urgent care centers, hospitals, and flooding them and overloading them. And it's not just the fact that the hospitals are overloaded with more people than they can handle with that problem, but also affects everyone else. So, for example, if the intensive care unit of the hospital is totally packed and there's no beds available, and somebody is having chest pain and a heart attack and needs to be rushed to the hospital and put in intensive care, and there's no room in the hospital or the intensive care unit for the person with a heart attack, then we have trouble. How are we going to treat that person with a heart attack or a ruptured appendix or whatever? So that it kind of has a rippling effect across that affects everyone. So right now, late in the game, state and local and even federal officials are realizing that we need to lift as many of the obstacles as possible for our private actors to respond to the surge in demand, which is a way of looking at it. And so they're doing so. I'm glad that they are, but I hope that everyone learns from this and doesn't go back to doing the same old thing once the crisis passes. They need to take a lesson from this and say, look how unready we were because of this. Maybe we should just leave these things out of the way.
Well, do you hold out hope that they don't go the other direction and say we need nationalized health care so that we'll be ready next time?
Yeah, there's always an opportunity for them to not get the right message. That's true. I mean, to me, it's an obvious. Their actions are suggesting that they recognize that the government top-down regulations are a problem. But, who's to guarantee they're going to be consistent with what they're doing right right now.
Well, Dr. Singer, thank you so much for your visit this week. We're a senior fellow at the Cato Institute, Department of Health Policy Studies. I appreciate your look into the Certificate of Public Need laws in Virginia and in general, comparing us to other states. Always gets our hackles up because we like to think of ourselves as superior to everyone else, and we love it when we can rub somebody's nose in it and say, no, you're not. So thank you so much. It's cato.org, and thank you for joining us this week.
I appreciate it. Thank you.
And thank you for listening all across the Commonwealth. Until next week, I'm Joe Thomas. So long, and thanks for all the fish.